Okay, so I'm going to move on now to a study where we were investigating a safety signal. And this was some work led by a person called Anthony Matthews, who was at the London School of Hygiene. And this was a question about PDE5 inhibitors, these are drugs like Viagra, and whether or not they were associated with malignant melanoma. So there was laboratory evidence that suggested this may be the case, and then there were some conflicting epidemiological studies from both the US and Sweden. And that was our reason for doing the study, that we had this kind of uncertainty over the answer to this question. So we did a cohort study which involved comparing people on a PDE5 inhibitor with people not taking a PDE5 inhibitor, and then seeing who gets malignant melanoma in those two groups. Okay, so fairly basic study design. And I'm going to start by telling you a bit more about how you might use electronic health records to do this kind of research. So we were relying on primary care data. So how do we get primary care data and then me as a researcher try to make sense of it for a study? Well, fortunately, there are lots of databases available containing these electronic health records where we can do these kinds of studies. And the example I'm going to give you, because it's the one I know, is the Clinical Practice Research Data Link. So it's a UK-wide database which contains primary care data and a little bit of linked secondary care data. So we have some hospital data included in there as well. And it's been active since 1987. So we have potentially a very, very long period of time over which we can observe patients that were treated in the UK. At the moment, there are around 20 million patients included in the data set, and this is actually increasing quite a lot at the moment. So it's potentially a very large resource that we can use. So I've got the structure of the database here, which I've simplified a bit so that you can see the kind of information. So at the bottom here, we've got the patient. So on each patient, we've got the demographic information that you would hope to have. So the year that they were born, their sex, when they start and end their observation, their ethnicity, all that sort of information that you would want to be able to know about somebody before you do research on them. We have clinical files, which record information about diagnoses, signs and symptoms, and the dates that they happened. Therapy files record all the prescriptions that are issued in primary care. We don't have information on hospital prescribing. So if you're interested in drugs for, say, hypertension or statins, then this is great data because they are prescribed in the UK in primary care. If you want detailed information about cancer treatments, they're not going to be in there. So we can't do studies on the effects of cancer treatments. We've got test information. So if you've had various blood tests commissioned by the primary care physician, then those results will be available. If a patient is referred on to secondary care, then that's also recorded electronically. There's a whole range of additional information. So for example, whether or not people smoke, how much alcohol they drink, their body mass index, all of that sort of information is recorded. Obviously, it depends on how honest the patient is. So for the BMI, that's fine because the doctor will measure it. Smoking and alcohol, well, people will say what they think the GP would like to know, or the doctor. So it may not always be honest, but there'll be some degree of accuracy there. Okay, so that's the sort of information that's recorded in the CPRD. This will be similar for other databases, and there will be some differences as well. Okay, so we've already talked about this in the patient file. Don't think there's anything else in there that you need. We also know if people die. So we have the date of death, which is very useful to know. also we have their socioeconomic status. So these are all variables that if we are worried about differences in patient groups, that we can potentially adjust for. Again, that's clinical files, which I've mentioned. I don't think there's anything else. Nope. The therapy files, nope. Again, we've talked about that. I guess just to point out the sort of information can be quite detailed. So as well as knowing what drug the patient was given, you can have things like the quantity of tablets they were given, the number of daily doses that was expected to translate into. But this can be quite variable in how it's recorded. Sometimes it's missing, sometimes it's there, and that can be problematic. So that's the data, which sounds quite involved and very detailed, but how do you get started to do a study using these data? So if we want to know, do drugs like Viagra cause malignant melanoma, where do we start? Well, it typically involves identifying people based on either an exposure, so a PDE5 inhibitor, or an outcome, like cancer, or both. Now, to do this, we need to develop things like code lists. So there are many different PDE5 inhibitors available, different strengths, different products. So we need to know the code for every one of those possibilities. Okay, so we need to put that list together. Drugs are relatively simple to make code lists for. Diseases can be very time consuming. So if you go to the GP and you've got cancer, the GP will enter a code onto their record for you to say what kind of cancer you've got. Now the GP is free to choose from a massive range of codes, and they will use whatever is most convenient for them to keep a record of you clinically. That's the purpose of the record, is for them to manage you clinically. Unfortunately, the purpose of the record is not for me to do research. It's a happy accident that I can use those data to do research, but we have to understand it's not the primary purpose of the data. So it means that if I want to identify cancer using the CPRD, I'll need to develop a really detailed code list that potentially captures every kind of cancer that could be recorded. And so, for example, if you take breast cancer, there will be many ways that the GP could record that a woman has breast cancer. So cancer has over 3,000 codes that could be selected in the CPRD. And we as researchers have to put together that list. So that's just a list for cancer with 3,000 codes. If you want to take any other disease, they will all also have similarly very detailed code lists. So it can be a very time-consuming process to put these lists together. If you get 2 investigators, they won't all agree on what should be in each list. And there will be some really obvious ones. So there'll be a code that just says breast cancer. Now everybody will agree that code should be in. But then there will be some obscure, unusual terms that are slightly ambiguous, and we need to decide, do we include them or not include them? And there will be disagreement. So I say that so that you can understand when somebody presents you their study result and says, here's the effect of this drug on cancer, that there are some kind of what I like to call fuzzy edges over how we define these illnesses, and you need to be aware that this is what we as investigators are doing all the time. Okay. As well as doing this for our exposure and outcome, we also have to do it for other patient characteristics. So other comorbidities, other treatments that they take, but then things like the smoking and alcohol information. Now, smoking is something that the GP, the primary care physician, will ask a patient about when they register. And the GP, the patient may or may not lie. They may tell the truth, they may not tell the truth, but the doctor may continue asking them over the years. So if you look at a patient's record, on the first day, it may say they're a smoker. 2 years later, it may say they are an ex-smoker. 5 years later, it may say that they're a never smoker. Now, all of these things cannot be true. So we as investigators have to decide, how will we interpret that record? Personally, I would interpret that they were a smoker at the start and then became an ex-smoker, and that I would never believe that they were a never smoker. But that's a fairly simple example, and it could be much more complicated than that. And you have to decide at a given point in time, what's my best guess at whether this patient is a smoker or not. So again, an example of why the data are complex and can be difficult to use. Okay.